Thank you, Dr. Ricella. Each presenter in session 5 has 6 minutes for the video presentation, followed by 6 minutes of question and answers. And our first presentation is titled Long-Term Outcomes Following Aortic Valve Replacement in Children with Conotruncal Anomalies, and is being presented by Bahaldin Assoufi from University of Louisville, Kentucky. Dr. Assoufi, floor is yours.
Aortic valve and root disease are common in children with conotruncal anomalies. For example, interrupted aortic arch patients have bicuspid valve and aortic stenosis. Truncus patients have truncal valve anomalies and AI. Transposition patients after arterial switch may develop neo-AI, and tetralogy patients may have aortic dilatation and AI. While the majority of those patients are treated conservatively, aortic valve intervention is needed in some. While this is usually done in older patients, when it's necessary in children, this is associated with significant challenges. We aim in the current series to study children with repaired conotruncal anomalies who underwent aortic valve replacement. We report late outcomes, including survival, transplantation, and reoperation need, and we examine factors affecting survival. Our data source were patients entered into the PCCC database. For long-term outcomes, we link those with the National Death Index and the Organ Procurement and Transplant Network databases, using identifiers such as name, gender, date of birth, and residency. And this was part of our NIH-funded R01 grant. Our patient cohort was between 82 and 2003. We identified 106 patients with conotruncal anomalies, and for comparison, we identified 871 with isolated aortic valve disease who underwent aortic valve replacement. In the conotruncal group, the most common pathology was truncus arteriosus in 38%, followed by transposition, interrupted arch, TORV, PAVSD, tetralogy, and one patient with corrected transposition. The most common valve type was mechanical in 68%, followed by homograft 20% and Ross 12%. The patient characteristics between the different valve types were not identical. Patients with Ross and homografts were younger, they were more likely to be neonates, they were smaller and had more genetic syndromes. In addition, the most common underlying pathology in Ross recipients was interrupted arch. In homograft recipients, it was truncus arteriosus. And while mechanical valves were used in all kinds of pathologies, they were more commonly used in the truncus patients. The Ross patients were more likely to have aortic stenosis or mixed disease, while the others were more likely to have aortic insufficiency. In addition, the Ross patients were more likely to require conoannular enlargement, more likely to have had prior balloon valvuloplasty or prior aortic arch repair. Overall, hospital mortality was 12%, 8% after Ross, 8% after mechanical, and 29% after homografts. On univariate analysis, homograft use, infant age, and underlying anomaly were associated with hospital death. However, on multivariable analysis, only infant age was a significant risk factor. And this is shown here, and as you can see, the discrepancy is mainly in the early phase between the infants and older patients. During the follow-up, 4 patients received heart transplantation, and there were 30 additional deaths, 2 after Ross, 5 after homograft, and 23 after mechanical. The 25 years transplant-free survival was 73% after Ross, 54% after mechanical valves, and 40% after the homograft. However, while valve type was not associated with death beyond hospital discharge, mitral valve surgery and underlying conotruncal anomaly with PAVSD and interrupted arch and corrected transposition were associated with late death. This is the competing risk model and shows that 10 years after aortic valve replacement, 13% had died or received transplantation and 1/3 received cardiac reoperation. For comparison, as I mentioned, we compared with those with congenital aortic valve disease, but that is not conotruncal. And we saw that the survival was lower in the conotruncal anomalies, 61% compared to 85%. However, conotruncal patients were younger, smaller, had more females, more genetic syndromes, more AI, more prior aortic valve and arch interventions, and more mechanical and homograft use. For that reason, we did match analysis and we matched 81 patients in each group. And in this match analysis, conotruncal anomalies were continued to have lower survival, 61% compared to 82% in the isolated congenital aortic valve replacement group at 25 years. This study is associated with limitations. This is a registry database. There might be confounding variables. We have no information on anticoagulation, bleeding, and thromboembolic events. And while our follow-up was complete for survival and transplantation, follow-up for reoperation outside the PCCC center might not be reported. And obviously, this is an older cohort. In conclusion, aortic valve replacement in children with conotruncal anomalies is associated with high operative death, especially in infants. We also identified that there is continuous attrition and transplantation need, and the long-term survival after AVR in this group is lower than that for isolated congenital aortic valve disease. The outcomes are related to the underlying conotruncal anomalies.
Dr. Rassoufi, for this interesting presentation. We have a discussant video for this abstract, and the discussant is Dr. Ilbawi from Advocate Children's Hospital, Chicago.
As usual, this is a very nice presentation and a thorough data analysis. Your findings that association of conotruncal abnormalities with aortic valve disease adversely affect outcome is very important, yet not an expected conclusion. This subgroup of patients has major complex cardiac pathology and needs multiple surgical procedures with potential for persistent postoperative residual lesions. Our focus, therefore, should be on whether we can improve on these outcomes, and if so, how. My first question relates to the surgical procedure used. Most of these patients had aortic valve replacement instead of valvuloplasty, although their valve could be suitable for repair. Do you think that favoring replacement could have delayed a needed earlier intervention in symptomatic patients, thus increasing their postoperative risk? My second question is, did the study identify certain preoperative factors such as presence of conotruncal residual lesions that adversely influence the outcome, yet potentially are correctable or avoidable? My third question addresses the timing of the valve surgery. Delaying valve surgery could result in subtle myocardial dysfunction and increased operative risk. What guidelines were used for timing of the valve replacement? Was there a difference in outcome if the procedure was performed before onset of symptoms? The final question, which relates to the previous one, have you compared the preoperative and discharge myocardial function of the survivors with those of non-survivors? Could you infer that protecting the myocardium throughout the course of the disease process might have improved the outcome? Thank you. I enjoyed your presentation.
Thank you very much, Dr. Ilbawi. Dr. Rassoufi, please turn on your camera. Camera is actually on, but could you unmute your microphone, and Dr. Jacobs will run the question and answers.
Thank you, Bogdan, and congratulations, Baha. This was a wonderful presentation, and it certainly shows the power of obtaining longitudinal follow-up of an existing registry. I think we should start by giving you an opportunity to answer the important questions that we just heard in the discussion of your presentation from Dr. Ilbawi.
Thank you very much, Dr. Ilbawi. Everything that I will say is going to be purely speculation, because I don't have the data to support it, but I completely agree with you that aortic valvuloplasty might have been underused in the population, with only 12% of those patients have undergone attempted aortic valve repair. This is an older group, and as we all know, the aortic valvuloplasty techniques have evolved. There are many people, including your center, who are reporting excellent results with bicuspid aortic valve with aortic stenosis. Also, we have techniques to repair aortic valve regurgitation with preservation of native tissue or by replacement of the native tissue. So obviously we have more techniques that we can utilize nowadays, and I feel like probably the current reality, more patients are undergoing aortic valve repair. But I agree with you. I feel like given the bad results, we should try to preserve the valve and give a shot for aortic valve repair to delay the aortic valve replacement as much as possible. As for the pathology, for long-term follow-up, and again, this is altered series, for survival beyond hospital discharge, some pathologies like corrected transposition and interrupted aortic arch have been associated with worse survival. We know, however, that the outcomes have improved for those two subsets of patients, so I feel like this might not be the case right now. Finally, I don't have data about the valve function or the cardiac function at time of discharge, but again, I agree with your speculation that trying to improve on those early on would affect long-term survival.
Well, thank you very much for those answers. I think we do have time for answering a couple of the multiple questions that are in the chat room. I'll start with a question from Jim Tweddle. Did you consider a matched comparison of patients who received a mechanical valve but were Ross candidates, i.e. double outlet right ventricle with pulmonary stenosis or pulmonary atresia or interrupted aortic arch patients?
The numbers would be very, very small, unfortunately. We have done overall match analysis, but we included the non-conotruncal congenital, and the results were in favor for the Ross, but I don't feel that this is fair answer for this population.
Okay, finally, I'll ask one more question from the chat room, where Dr. Calderon asks if you can comment on the mode of death for the patients with mechanical valves, thrombosis, embolic events. Were you able to access that information from the link to the National Death Index?
We have some. The reason I did not want to present that because I did not feel it's complete and unreliable. As I mentioned, this is old cohort, and if the death occurred during the time those patients were followed at the PCC center, that submits the data to 3CCC, we would be able to know. But when we're getting that from the National Death Index, it's like called cardiac, non-cardiac. I'll tell you the majority were cardiac, but I cannot comment, unfortunately. That is, especially when those deaths happened when the patients like 18, 20, 22, these are adult patients that don't follow up in the same institution anymore.
Well, thank you, Baha, for an excellent presentation and an outstanding discussion. There's plenty more questions, but I think to stay on schedule, we're going to need to move on to the next presentation, and I'll turn it back over to Bogdan to introduce the next talk.
The next talk is from Dr. James Meza from Duke University, and he will present an abstract titled Sustained Total All-Region Perfusion During the Norwood Operation is Associated with Improved Postoperative Recovery. Dr. Meza, the floor is yours.
I am Jim Meza, presenting on behalf of my co-authors from Duke University Medical Center. We are grateful to the Congenital Heart Surgeons Society and the European Congenital Heart Surgeons Association for the opportunity to present sustained total all-region perfusion during the Norwood operation is associated with improved post-operative recovery. We have no disclosures related to this work. The Norwood operation is performed as stage 1 palliation for congenital heart defects such as hypoplastic left heart syndrome and other similar single ventricle lesions. It includes ligation of the patent ductus arteriosus, enlargement of an atrial septal defect, reconstruction of the aortic arch, and establishment of a source of pulmonary blood flow using a Sano shunt at our institution. Traditionally, deep hypothermic circulatory arrest or regional cerebral perfusion have been utilized while leaving the lower body ischemic. Survival to hospital discharge nationally is around 85% in the current era. In theory, a configuration which allows for simultaneous perfusion of the brain, heart, and lower body throughout the procedure should further enhance recovery and reduce the risk of end organ injury. Here, we describe a technique that combines continuous coronary perfusion with regional cerebral perfusion and continuous lower body perfusion to eliminate ischemic time in all vascular beds and to allow the Norwood operation to be performed at warmer temperatures. We hypothesized that sustained total all-region perfusion, or STAR perfusion, would shorten cardiopulmonary bypass and procedural times and expedite postoperative recovery. The operative technique begins with the establishment of cardiopulmonary bypass via innominate arterial and right atrial cannulation. The patient is next cooled to 32 degrees Celsius. The transverse aorta is clamped and the descending aorta is cannulated with a 4 French olive tip catheter. Cerebral and myocardial perfusion are maintained through the innominate arterial cannula. The coarctectomy and interdigitating repair are next performed. We then convert to 3-region perfusion by sliding the innominate arterial cannula distally, placing a cardioplegia spike with tubing connected to the innominate arterial cannula for myocardial perfusion, and keeping the descending aortic cannula in place. This allows for the atrial septectomy and proximal Sano anastomosis to be performed, and for the Damas K. Stansel anastomosis to be completed. The innominate arterial cannula is then pulled proximally back into the descending aorta, and the cardioplegia spike is converted to a root vent, and the descending aortic cannula is removed through the suture line, allowing for de-airing and rewarming. The distal Sano anastomosis is performed for completion of the Norwood operation. Our data was gathered using our institutional STS data supplemented with targeted chart review. In total, from 2012 to 2019, 51 primary Norwood operations were performed, 21 with STAR perfusion versus 30 using conventional cerebral perfusion only. Descriptive statistics for preoperative, operative, and outcome characteristics were computed and compared. STAR perfusion was associated with shorter median cardiopulmonary bypass times versus conventional perfusion at 161 versus 226 minutes. Myocardial ischemia was eliminated at 0 versus a median of 90 minutes of cross-clamp time. Median total operative time was also reduced by over 3 hours at 319 from 514 minutes. All comparisons were statistically significant. Survival to hospital discharge was similar. Notably, 20 out of 21, or 95 patients who underwent the Norwood with STAR perfusion survived. However, we noted improvements in morbidity during postoperative recovery. Those who underwent the Norwood with STAR perfusion experienced more rapid normalization of serum lactate at a median of 19.3 versus 26.5 hours, demonstrated lower median peak serum lactate levels at 8.6 versus 10 millimoles per deciliter, and waited fewer days until chest closure. at a median of 3 versus 5 days. These comparisons were again statistically significant. Star perfusion is a safe technique that eliminates ischemic time to the heart and lower body and allows for the procedure to be performed at warmer temperatures. Improvements in operative time, hemostasis, and organ function and postoperative recovery were noted as well. Thank you.
Thank you very much. And we have discussant video for this abstract. The discussant is Dr. Emre Belli from Jacques Cartier Center in Massy, France.
I congratulate Dr. Meza and colleagues for this nice presentation, and also I thank both two associations, CHSS and EXA, for the privilege to discuss this paper. Aortic arch repair in neonates has become simpler with outstanding outcomes since many years, and after deep hypotomic circulatory arrest, regional cerebral perfusion has shown some at least short-term advantages and is used routinely in many centers around the world. I have two questions. The first, I cannot understand why when you use whole body perfusion with innominate artery, descending aorta and coronary, you have shorter cross-clamp time than deep hypotomic circulatory arrest or regional cerebral perfusion. This is the first question. And the second, when you're performing classical hypoplastic left heart with aortic and mitral atresia, you can do a significant part of the procedure without cross-clamp. That means after ligation, you can reconstruct the pulmonary outflow and also enlarge the ASD, remaining aortic arch repair, which can take 30 or to 40 minutes without any hurry. Do you think this is justified to avoid 30-40 minute cross-clamp myocardial ischemia and to perform a coronary perfusion, which eventually can result in myocardial edema at early postoperative period? Thank you very much for your presentation and for the privilege of the floor.
Unmute your microphone. Thank you.
Yeah, we'll start the discussion by having Dr. Meza address the important questions from Dr. Emre Belli, and then if we have time, there's a number of excellent questions in the chat room.
Hello, good morning. Thank you for the privilege of presenting our results here this morning. It seemed like the question really was two questions that are of a similar flavor. We do perform the Norwood operation without cross-clamp at our institution. We really believe that the advantages of this providing myocardial perfusion during this time are seen in our results and especially in postoperative recovery. For example, we haven't shown a statistically significant time to urine output, but we've seen a trend toward earlier urine output. We've seen a more rapid clearance of lactate. And we think that has to do with more rapid myocardial recovery as part of the reason for employing this technique.
Well, thank you very much. We do have time for a couple of quick questions. I'm going to ask you two questions that kind of consolidate the multiple questions in the chat room. One comes from Tara Karamlu that asks you to comment on the benefits of the strategy that you've described versus the strategy Jim Hamill has described for descending aortic cannulation. And the second question relates to your strategy for providing continuous myocardial perfusion in patients with aortas less than 2 millimeters in size, a question that was answered by a number of our colleagues, including Brett Mettler.
Sure. I think I'll take the second question first in terms of aortas less than 2 millimeters. We are employing this technique with aortas less than 2 millimeters. That's when we use a olive tip catheter that's then connected to the arterial cannula that's in the innominate artery. So that has not been a limiting factor for us. We've repaired aortas as small as in the 1.5, 1.8 millimeter range with this technique. As far as the technique that is propagated by the Nebraska group, I think it's a similar approach. I don't know if there's any specific benefits versus our technique. I think ours is an alternative.
Well, thank you very much for a wonderful presentation and some precise and concise answers. In the interest of time, we'll move on to the next presentation. I'll turn this back over to Bogdan to introduce the next speaker.
Thank you, Jeff. The next presenter is Dr. Al-Sufi again, and the title of the abstract is Lack of Correlation Between Severity of Preoperative Mitral Regurgitation and Left Ventricular Dysfunction and Survival in Patients with Anomalous Left Coronary Artery Origin from Pulmonary Artery.
Mitral valve regurgitation is common in patients with Al-Kappa. The mechanism of MR include ischemia, LV dysfunction, and annular dilatation, although some patients have organic mitral pathology. The management of MR during Al-Kappa repair is controversial. While the expectation is that the MR will improve with revascularization, there are concerns about the effect of MR on early morbidity, patient recovery, and the worry of persistent significant MR following Al-Kappa repair. We aim in the current series to study children with treated Al-Kappa and to explore the relationship between MR and LV dysfunction and explore the effect of significant MR on Al-Kappa repair outcomes. Our patient came from the PCCC database, and for long-term outcomes, we link those patients with the National Death Index and the Organ Procurement and Transplant Network databases using identifiers such as name, gender, date of birth, and residency. And this was part of our NIH-funded R1 grant. Between 1982 and 2003, we identified 173 patients who underwent Al-Kappa repair and had known preoperative MR degree. The repair strategy was coronary implantation in the majority, followed by Takeuchi repair and cabbage and ligation of the coronary in 4% each. We identified that 40% of those patients had moderate to severe MR, while 60% had trivial to mild. When we compared between the two groups, patients with moderate to severe MR were younger and smaller, although the distribution of age less than 1 year versus older was not significantly different. Interestingly, the incidence of severe left ventricular dysfunction was not also significantly different between the two groups. And this scatter plot shows the distribution of mitral valve regurgitation based on the LV function. In yellow, you see the patients with trivial or mild MR, and in blue, you see the patients with moderate to severe MR. And you can see even those with severe left ventricular dysfunction, many of them had trivial or mild MR, while even those with good LV function, many of those had moderate to severe MR. And when we looked at the infant age, again, even those with significant left ventricular dysfunction many of them had mild to trivial MR. When we compared between the two groups, the type of surgical repair was not different, although naturally mitral valve repair was performed in those with moderate to severe MR. However, it was only done in 17% of those patients. When we looked at the hospital outcomes, mechanical circulatory support was necessary in 4.5% and was not different between the two groups of patients. Similarly, hospital death was about 11.6% and again not different between the two groups of patients. And when we looked at multivariable analysis for hospital death, none of the factors that we examined was associated with survival. Interestingly, when we looked at the long-term survival, there was little attrition beyond infancy, with 1 year transplant-free survival of 86% and 20 years survival of 84%. And when we looked at different mitral valve regurgitation group, you can see that the moderate to severe MR group did not have worse survival compared to the trivial and mild MR group. And when we looked at the ventricular dysfunction, also effect on survival, you can see that it was not significant. And when we looked at the interaction between the mitral regurgitation degree and the ventricular dysfunction degree, again, none of those groups was associated with worse survival. Our study is limited. It's a registry database. We don't have any anatomic information about the mitral valve pathology. This is definitely surgeon and institution bias with regards to the need or the performance of mitral valve repair. And we don't have serial echocardiographic data of the progression of MR, LV size, or function. However, in conclusion, we found that significant MR is present in 40% of patients with L-CAPA. Although the MR is related to ischemia and LV dysfunction, there was no clear correlation between LV dysfunction degree and mitral valve regurgitation severity. Despite that only a few patients received concomitant mitral valve repair, the significant preoperative MR did not affect mechanical support, read, hospital death, or transplant-free survival. Those findings might support the expected management of MR at time of L-CAPA repair.
Thank you very much, Dr. Al-Soufi. And we have discussant video for this abstract again. The discussant is Dr. Jennifer Romano from the University of Michigan.
Hi, my name is Jennifer Romano, and I'm from the University of Michigan. Dr. Al-Soufi, thank you for a very nice presentation on your sizable institutional experience with L-CAPA, averaging approximately 9 cases per year. Your study conclusions certainly support my training and personal approach to L-CAPA, which is to leave the mitral valve alone at initial repair. I have a few questions for you. First, what drove the decision for either reimplantation versus a Takeuchi repair? Was this surgeon preference or era dependent given the long time frame of your study? And what was the rationale for a CABG or ligation in select patients? Second, your hospital mortality was notable and on the high end at 11% in my perspective. What was the cause of death, and would these patients have been considered for a VAD as a bridge to transplant? And finally, in the few patients that did receive a mitral valve repair, how was the decision made to intervene? What were the long-term outcomes for this specific group of patients, and what repair technique was employed? Again, thank you for a very nice presentation and the privilege of the floor.
Dr. Al-Soufi, please unmute your microphone. Thank you.
Thank you very much for your comments. I apologize if it wasn't made very clear that this is not a single institution experience. This is more like of a registry database, but we do have access to operative notes and lots of information. So I can answer some, but not all of your questions. With regards to the choice of operation, I am sure there is institutional and surgeon preference. However, you can see a little bit of trend for more reimplantation in the more recent era. We did look at 3 different eras, and there is a trend that is not statistically significant for more implantation in the more recent era, and also older patients tended to get more Takeuchi. As with regards to the VAD, I feel like the number is low compared to the number of deaths, and I feel like it might have been underutilized, and that might be because of the older nature of this patient cohort. I feel like probably no patient should be allowed to die with the L-CAPA without being on mechanical circulatory support and without being considered for transplantation. So I agree with your observation. Unfortunately, I do not have great information about what was the decision making in those few patients who underwent coronary artery ligation. But that definitely would not be my choice, as several series have shown that establishment of dual coronary system is associated with better survival and better freedom from reoperation.
Well, thank you, Baha, for answering those questions. And we have a number of questions in the chat room. I wanted to bring forward a question from Hani Najm. Hani brings up the topic that 11% mortality is substantial. Was there therefore an era effect? Clearly, the PCCC is a legacy database that preceded the STS database and led to a lot of the foundations from which we ultimately built the STS database. It's a tremendous legacy, but at the same time, some of the data are a little bit older. Can you comment on the value and also the challenges of using this legacy data? And also, as Dr. Najm brought up, the era effect.
Yeah, within the same, this series goes from 1982 to 2003. We split that based on the number of patients overall in that database that we have to 3 eras. For the Al-Kappa, there was minor improvement that did not reach statistical significance, but I think that's also you're not powered to demonstrate improved survival. But I do agree with you that survival should and actually is better in the current era. We're talking about the early survival. As for long-term survival beyond the Shah, even in the oldest era, that has been excellent. So I don't think that has changed.
Well, thank you. We'll ask one more question, which comes from Jim Tweddle. He asks, does the PCCC database contain data concerning the mechanism of mitral regurgitation? And can you comment on the relationship between mechanism and outcome?
We are relying basically on the description from the echocardiograms and from the ORs, and that varies. So unfortunately, as I mentioned in my limitation, we don't have anatomic information whether this patient had organic dysfunction or not. Only 17% receive mitral valve repair, and subsequent to that, unless the patient has moved to a different center, we are aware of 7 patients who required mitral valve reoperation. 6 in the moderate to severe group. 2 of them had prior mitral valve repair, and 2 of the mitral valve reoperations were for stenosis. So as you can see, the numbers are not large to tell you that there is any major benefit from mitral valve repair or not, and especially when you take into account patient's preference, surgeon's preference.
Yeah, I think that's a pretty precise answer, and the answer that can be given from this particular data set. Tweddle in the discussion room pointed out that structural abnormalities of the mitral valve with severe MR has been considered an indication for mitral valve repair. So I think that's, and then George Saris commented ischemic MR is related to regional and not necessarily global LV ischemia. So I think that discussion ties into what you just mentioned. Clearly we could continue this dialogue, but I think to stay on schedule, we're going to have to move on. Dr. Al-Sufi, thank you for 2 outstanding presentations this morning. Strong work. And I'll turn it back over to Bogdan to introduce our next speaker.
Thank you, Jeff. The next paper is titled Contemporary Management Patterns of Neonates with Tetralogy of Fallot Across the United States. It's being presented by Dr. Karthik Ungapal.
Hello, everyone. My name is Karthik Vengapan. I am the research fellow for the congenital heart surgery team at Cincinnati Children's Hospital Medical Center, and I'm a PGY4 general surgery resident at University of Cincinnati Medical Center. I would like to thank the Society for giving us the opportunity to present our study. Our study is called Contemporary Management Patterns of Neonates with Tetralogy of Fallot Across the United States. I have no conflicts of interest to disclose. For decades, there has been ongoing debate about whether neonatal repair or shunt palliation is superior. This debate has become more complicated with the advent of PDA and RVOT stenting. While these new strategies have significantly increased in popularity over the last few years, as of the manuscripts describing the utility of the different strategies, do we really know what happens to neonates admitted with tetralogy across the U.S.? The purpose of this study is to describe the evolving in-hospital management strategies for neonates who are diagnosed with tetralogy of Fallot across the U.S. The FIS database was used for this retrospective descriptive study. It was used to identify the first recorded admission for patients 0 to 1 month old with a diagnosis of tetralogy of Fallot from 2010 to 2019. ICD-9 and ICD-10 diagnosis and procedure codes were used to identify the tetralogy of Fallot diagnosis, excluding pulmonary atresia and CAVC, as well as associated procedures. (6,021) such admissions of neonates with tetralogy of Fallot were identified. 34% of these neonates underwent an intervention, 66% did not. Within the intervention group, 59% underwent full repair, 30% underwent shunt, and 9% underwent stent. A few things to note: the percentages here exclude 1.3%, which was 27 patients who had 2 different simultaneous interventions recorded. Also of note, 22% of all interventions in the past 2 years were stents, and we will talk about the changing proportion of interventions over time later on in this presentation. First, we compared the intervention to the no intervention group. Patients in the intervention group were younger, more often had other CHD diagnoses, were more frequently on TPN, mechanical ventilation, and ECMO. Length of stay was significantly higher in the intervention group as well. However, in-hospital mortality was significantly higher in the no intervention group. Then within the no intervention group, we compared those who died in the hospital during their first admission versus those who were able to reach discharge. Patients who received no intervention and died in hospital were younger. They were generally more ill as well, more frequently on TPN, mechanical ventilation, and ECMO. Otherwise, no intervention patients who died and those who were discharged had similar demographics. Next, within the intervention group, we compared the types of interventions to each other. Patients who underwent full repair were generally more ill, more frequently on TPN, mechanical ventilation, ECMO, and had longer length of stay. Patients who underwent stent placement were most likely to have other CHD diagnoses. In-hospital mortality was similar across all groups. We then compared the intervention types across the regions. Overall, interventions were most frequent in the West. Within the intervention group, full repairs were significantly more frequent in the Northeast. Shunts were significantly more frequent in the Midwest. And stents were were most frequent in the South. While the rate of no intervention and full repair have remained steady over the last 10 years, shunting has decreased and stenting has increased in recent years. There are a few limitations regarding our study that we'd like to make note of. Important factors such as prematurity are not consistently accurate variables in the FIS database, limiting our ability to include them in analysis. And importantly, this study is a work in progress. Further work will be done to differentiate how the proportion of interventions versus no interventions, as well as different types of intervention, change across eras. And further analysis will also be done to categorize other diagnoses in addition to CHD that can impact decision making. In conclusion, although the majority of neonates with tetralogy of Fallot are discharged from their first hospitalization with no intervention, over 1/3 undergo some intervention. Though the proportion of neonates intervened upon is unchanged over the past decade, the types of intervention most commonly performed have changed. significant differences in the proportion of different interventions performed exist across regions of the USA. Thank you. Thank you.
Thank you very much, Dr. Tangepan. And the discussant for this paper will be Dr. Giovanni Stellin from the University of Padova, Italy.
Giovanni Stellin discussing the abstract for presentation number 14, Contemporary Management of Neonates with Heteralgia Fallow across the United States. Authors are studying a cohort of neonates who have been selected from the Pediatric Health Information System between 2012 and 2015 with a diagnosis of Tetralogy Fallot. Cases with pulmonary atresia and complete AV canal in association have been excluded. There is no mention, however, to cases who can present in association with the absent pulmonary valve syndrome and double lateral right ventricle. In the last lustrum, there has been a significant improvement of low-risk interventional procedures such as PDA stenting, RVOTO stenting for palliating symptomatic neonates with such a disease and then defer correction later in life. Question number 1. Do you think that your analysis, which goes back to a population which has been observed 5 to 9 years ago, might reflect a contemporary management as you are stating in your title? Each institution in the USA can apply different criteria for patients, for selecting patients for complete repair versus the palliation. It is intuitive, however, that the lower risk of patients with a favorable anatomy, normal body weight, no pre-existing comorbidities are usually selected for repair. Rather, high-risk patients are likely selected for palliation. Question number 2. Have you checked the preoperative conditions for each group? Were they balanced? Surgical repair of Tetralogy Fallow in neonates still remains nowadays a challenge, particularly when dealing with a very fragile myocardium, enclosing the ventricular septal defect and resecting the right ventricular flow tract. Question number 3. How many patients within the primary repair group need a reoperation for A, residual ventricular septal defect, B, residual right ventricular outflow tract obstruction, C, complete AV block?
Well, first of all, I'd like to congratulate our presenter of this presentation, because it's nice to see a general surgery resident up and giving a talk at the CHSS. That's a huge big deal. And I know that the quality of the presentation that you gave is an order of magnitude better than anything that I could have done as a general surgery resident. So outstanding job, and congratulations. I'll turn the floor over to you and give you the opportunity to address the questions raised by past EXA President Giovanni Stellin.
Yes, thank you so much for the compliments. So to address the questions posed, first question about if it reflects contemporary management truly, because with the abstract was dated 2012, 2015. So the data presented actually does reflect more contemporary data, actually 2012, 2019. When we wrote the abstract, we were unable to extract ICD-10 information, and the transition from ICD-9 to ICD-10 reporting happened in October of 2015. So once we were able to do that, we updated the results. So the results presented are more of a contemporary management reflection. And as for the second question, are low risk patients selected for repair and high risk for palliation? That was definitely the first thought. We did start to see as the presentation when we started comparing the groups, that intervention patients in general, while they had more CHD diagnosis, were also had characteristics that made them seem more on the ill side, like they were on TPN, they were on mechanical ventilation, more on ECMO than the no intervention group. This may be a matter of just the pure number of patients in each group, and while in the no intervention group, if they were discharged, they were likely, there's probably more of a measure of extremes in the no intervention group. If they were discharged, they were likely pretty healthy, didn't require any of those things. But the lower number of patients who did not receive an intervention who died also had a significant portion of patients on ECMO and TPN, et cetera, who were not healthy. So overall, we did not see that they were generally lower risk if they went for repair, but it may be due to the significant number of patients who were discharged in the no intervention group who were likely on the healthier side. In regard to pre-op conditions and if they were balanced between those who were repaired and those who were palliated, the FIS database is a little bit limited as to what is in particular a pre-op condition. Most of the things like TPN, ECMO are simply stated as a yes or no. So it could have been at any point in their hospitalization. So unfortunately, we can't specifically comment on that. In terms of who received a reoperation for specific situations such as complete AV block and RVOT obstruction, that unfortunately is also not available to us. We can simply see if they had certain cardiac interventions in different admissions, but usually it's listed as the primary surgical intervention, which is either tetralogy flow, repair, or palliation.
I'd like to first of all congratulate you again for a great presentation and also for being able to very thoroughly answer a whole slew of questions. Great thinking on your feet and nice job. And I think every CHSS member just loves to see a general surgery resident presenting here. So congratulations. Your presentation generated at least a dozen good questions in the chat room, but I think we're going to need to move on to the next presentation to stay on schedule. Congratulations for your work, and we look forward to seeing you as a CHSS member one day. I'll turn it over to Bogdan to present now, to introduce the final presentation of the session.
Presenting next is Dr. Parth Patel from Indiana University with an abstract titled Risk Factors for Reoperation After Arterial Switch Operation.
Hello, my name is Parth Patel, and I would like to thank the Society for allowing me to present our abstract titled Risk Factors for Reoperation After Arterial Switch Operation. We have no disclosures. The arterial switch operation was introduced by Dr. Jatain in 1975, and it became the mainstay in treatment for detransposition of the great arteries, DTGA, in 1984, championed by Dr. Castaneda and others soon thereafter. The first and second generation of switch patients are now entering their fourth and fifth decades of life, and there is a paucity of data regarding the incidence and nature of reoperations in these patients. Risk factors for reoperation after the arterial switch remain to be elucidated, and so the purpose of this study is to explore the timing, nature, and risk factors for reoperation after the arterial switch for DTGA. This is a single-center retrospective chart review of our experience with the arterial switch in DTGA from 1986 to 2017. The 403 patients were broken down by decade into 4 eras. Era 1 was from 1986 to 1989 with 34 patients. Era 2 was from 1990 to 1999 with 163 patients. Era 3 was from 2000 to 2009 with 115 patients. And Era 4 was from 2010 to 2017 with 91 patients. Of note, there was a change in our operative technique in November of 1989, prior to which all cases were done under hypothermic circulatory arrest. Primary outcomes were mortality and reoperation, and the statistical analysis we performed is on the right side of the screen. These are our patient demographics. Median age at operation was 9 days, and it was not different between the 4 eras. 10% of patients had Taussig-Bing anomaly, 37% of patients had ventriculoseptal defect, and 9% of patients had arch abnormalities. The incidence of these co-diagnoses was not different between the 4 eras. 33% of patients had coronary anomalies, and the incidence and nature of the coronary anomalies was not different between the 4 eras. The majority of patients, 73%, required preoperative balloon atrial septostomy. Kaplan-Meier analysis shows that 5-year survival increased from 76% in era 1 to 88% in era 2 to 92 and 93% in eras 3 and 4. This is a competing risk analysis comparing the cumulative incidence of death versus reoperation, and survival without reoperation at 10, 20, and 30 years was 84%, 79%, and 79%. Of the total 403 patients, 374 did not require reoperation. 29 patients required at least 1 reoperation. 6 patients required at least 2 reoperations, and 1 patient required 3 reoperations. The reoperations were broken down into 4 basic categories: pulmonic and right-sided interventions with 17 patients, aortic and left-sided interventions with 8 patients, coronary interventions 5 patients, and 7 patients required some other intervention. The median time to pulmonary and right-sided interventions was much sooner at 2.7 years postoperatively compared to aortic and left-sided intervention at 13.1 years postoperatively. On multivariate risk factor analysis, postoperative ECMO and Taussig-Bing anomaly were risk factors for any reoperation. For right-sided interventions, Taussig-Bing anomaly was a risk factor specifically for pulmonary valve intervention. For left-sided interventions, ventricular septal defect was specifically a risk factor for aortic valve intervention, and preoperative pulmonary artery banding was a risk factor for aortic root intervention. In conclusion, early mortality in the current era is low at 3%, and 5-year survival in the current era is 93%. 30-year survival without reoperation is 79%. Pulmonary valve and right-sided interventions tend to occur sooner than aortic valve and left-sided interventions. All patients status post-arterial switch require lifelong follow-up, particularly those with ventricular septal defect, Taussig-Bing anomaly, and previous PA banding. I would like to thank the Society again for allowing me to present this abstract. I would like to thank my mentors, Dr. Brown, Dr. Herman, Dr. Rodefeld, and Dr. Turrentine, for their mentorship and guidance. I would like to thank the staff at Riley Hospital and the Riley Data Center for assisting me with this study. And lastly, I would like to thank our patients for allowing us to care for them.
Thank you very much, Dr. Petal. And the discussant for this paper is Dr. Kirk Cantor from Emory University.
My name is Kirk Cantor from Emory University in Atlanta. Thank you for the opportunity to review this interesting presentation by Dr. Patel from Indiana. About 403 patients underwent an arterial switch procedure over several decades with excellent results. I have a few questions. A small question is that the patient, it is stated that 374 patients did not require reoperation. However, this does not include the patients who died and therefore had no opportunity for reoperation. So the 3% or more patients who had early mortality should be excluded, and that 374 patients should be fewer. I'm struck by the low number of reinterventions. During the time period, did the authors change their methods of performing the comp maneuver to the use of pantaloon patch? It seems to me that their reintervention rate is commendably low. Also, even though 6% of the patients had previous pulmonary bands and 8% had repair of interrupted arch or coarctation, both of which are risk factors for neo-aortic valve failure, even on their long follow-up, there were very few aortic valve interventions. What do the authors attribute that to? And finally, I'd like to ask why ECMO had such a high risk of re-intervention. Presumably, these patients had technically satisfactory operations and just had heart failure. Why would that be a risk factor? Can the authors speculate on that? Thank you for the opportunity to discuss this paper.
So we'll turn this over to Dr. Patel to address the important questions from Dr. Cantor. Interestingly enough, many of the questions Dr. Cantor raised are also questions in the chat room. Congratulations, Dr. Patel, on an excellent presentation. I think you've made Dr. Brown and the team in Indiana quite proud, and we'll turn the platform over to you to answer some questions.
Thank you, Dr. Jacobs. So to answer your questions, Dr. Cantor, thank you for those excellent questions. To your first question, you're correct. So 32 patients died early and did not have the opportunity for reoperation. And so of the 371 late survivors, 342 did not require reoperation. With regards to your question regarding our technique, we do perform the LeCompte maneuver, though we have not changed how we perform that through our 4 eras. We do also use a very generously sized pantaloon patch. Dr. Brown says use double the size of the patch you initially expect. And so that we feel is critical to our low rate of reintervention on the right side. With regards to your question for our low incidence of left-sided reoperation, I don't have a great explanation for this. I do know that in literature, when aortic reconstruction after the LeCompte maneuver is described, I've seen that some centers use make a J cut in the neo-aortic sinus prior to proximal aortic anastomosis, and then they reimplant the coronaries and then reconstruct the aorta using the superior aspect of that coronary button as part of the proximal aortic anastomosis. We approach the aortic reconstruction a little bit differently. So prior to aortic reconstruction, we mark the commissures externally, then perform the proximal aortic anastomosis, then remove the aortic cross clamp to distend the aorta, and mark where we think the left coronary implantation should be. We then reapply the cross clamp, punch out the marked area, and perform the left coronary anastomosis. We then repeat this process for the right coronary artery. This may be the reason for our low left-sided reoperation, but I would just be speculating. Lastly, with respect to ECMO being such a strong risk factor for reoperation, I have no obvious reason or rhyme or reason for this. However, I'll delve into the data a little bit deeper, see if I can find a sensible link, and get back to you. But I don't have a great explanation.
Well, Dr. Patel, thank you for your systematic approach to all of the questions from Dr. Cantor, and thank you for an excellent presentation. Again, I think that the team in Indiana is proud of you right now, and Dr. Brown, I think, is somewhere smiling. With that, we'll move on to what is actually the true final presentation of this session from Dr. Backer, and I'll turn it over to my good friend, Dr. Marashevsky, to introduce the actual last talk of this session.
Thank you, Jeff. So the final paper of the session will be presented by Dr. Carl Baker at some initial results with a novel expanded polytetrafluoroethylene PTFE pulmonary valve conduit.
Good morning, and hello to all my friends at EXA and CHSS. It is a real honor for me to be the one this morning to present to you our initial results with a novel PTFE-based pulmonary valve conduit. I do want to recognize my co-collaborators on this project, Dr. Mark Galanowitz from Nationwide Children's and Drs. Chris Baird and Pedro Del Nido from Boston Children's Hospital. I also need to disclose that I am a consultant to W.L. Gore and Associates. While all congenital heart surgeons know that pulmonary valve conduits provide limited durability, a novel approach to RV to PA conduits was described by Dr. Masaki Yamagashi from Japan, who designed and hand-constructed his own expanded PTFE conduits with a fan-shaped PTFE valve. Dr. Yamagishi has now implanted these in over 900 patients starting in 2001, so has nearly 20-year follow-up. If one overlays the graph of the freedom from explantation of these PTFE conduits with the standard current conduits available, one can see that the PTFE conduit has a much stronger track record. The novel pulmonary valve conduit that we are discussing in this paper is industry manufactured and is made of expanded PTFE. This is stretch graft, which is familiar to most congenital heart surgeons. Within the mid portion of this housing is a tri-leaflet valve that is made of a flexible biosynthetic tissue using advanced proprietary material. The valve itself is designed to be resistant to calcification and structural valve degeneration. Again, it is industry manufactured, and all conduits were 20 millimeters internal diameter. The study was a prospective, multi-center, single-arm study. This is an early feasibility study established with the FDA to evaluate safety and performance. The primary endpoint was a composite at 6 months of valve-related mortality and device-related reintervention. Secondary endpoints were change in RV volume, pulmonary regurgitation, and pressure gradient over time. The major inclusion criteria were that a subject was suitable for implantation with a 20 millimeter device as determined by the screening committee. All patients were over 5 years of age. All patients met clinical criteria for RV to PA conduit. Patients were maintained on a single antiplatelet medication for a minimum of 3 months. They then had routine clinic visits and transthoracic echocardiograms with cardiac MRIs to be performed at 6 months post-implant. The enrollment began in June of 2018 and concluded in November of 2019. 6 subjects were implanted in Boston, 5 at Nationwide, and 5 in Chicago. The age range was from 6 to 17 years with a mean age of 11.5 years. 9 males, 7 females, and body surface area ranging from 0.8 to 1.57 meters squared. Through 6 months follow-up, the results are as follows. There was no mortality, there was no calcification noted by echocardiogram, no patient developed endocarditis, and no thrombus was detected again by echocardiogram. The mean pressure gradient over time is shown in this graph. Each colored line is an individual patient. At 6 months post-implant, all patients were well below 20 millimeters of mercury RV to PA gradient. The mean gradient was about 12 millimeters of mercury. Regarding pulmonary valve regurgitation, at 6 months follow-up, 75% of the patients had stable, mild pulmonary valve insufficiency, and 25% had no pulmonary valve insufficiency. In conclusion, 6-month follow-up of a novel PTFE pulmonary valve conduit shows that the primary endpoint was met in our 16 patients. There was no mortality and there were no unexpected findings. Secondary endpoints were also met in that there was encouraging hemodynamic performance with a pressure gradient less than 20 millimeters of mercury in all patients. The pulmonary valve regurgitation was stable and mild. There was no calcification, no endocarditis, and no thrombus formation. Subject evaluations are ongoing, and we await the results of MRI imaging. Again, it was a pleasure for me to present to you the 6-month follow-up of a novel pulmonary valve conduit. I'm eager to answer any questions that may occur. Thank you very much.
Thank you, Carl, for a very nice presentation of some important new technology. We have some time for some questions, and there's a number in the chat room. I'll start by asking you, can you comment a little bit on how you envision the role of this valve that you just described versus both the transcatheter Melody valve and also maybe the Gore-Tex bicuspid valve that's been described and utilized by Jim Quintessenza?
Well, thanks, Jeff. I think to address the second question first, I think Jim's valve that he's been hand manufacturing, much like the valves made in Japan, is sort of the origination of this idea. I do think that for us congenital heart surgeons, a valve that's manufactured by industry to very specific standards using some of the same techniques and technology should clearly, in my mind, probably be a better valve. So that's the goal. Regarding the role of this valve versus percutaneous valves. I think one thing about this valve is that it is set up so that there are gold bands on the valve that can be seen radiographically, so that the valve is teed up for the placement of a percutaneous valve at the appropriate point when that time would come.
Well, thanks. And I thought it was important to acknowledge the work that Jim Hughes done in this area that in many ways laid the groundwork for some of this. Elizabeth Stephen states, exciting. What are the next steps? More sizes, making distal grafts more closely match material properties of the PAs. So she kind of wants you to comment on where this technology is going to go next.
Well, our next step is to have multi-center trials with probably around 10 to 15 centers. The company is going to be manufacturing 4 different sizes of valves, 12, 16, 20, and 24. So we will be able to apply it to a broader range of patients. And hopefully that initiative will start in late 2021 or early 2022.
Okay, and then our program chair asks, this is Luca, would you use these in patients with distal disease and high pulmonary artery pressure?
I believe that I would. So far, we have had some patients with those same issues, and these valves appear to be very strong. A further goal at some point is to be able to use these valves on the left side. So I think much like Dr. Kalfa's presentations, the makeup of the valve itself can be changed, altered to increase the strength and have different potential uses for the valve. But I think it's going to be good even for patients with high PA pressures.
So sticking with that theme, Dr. Tweddle asks, can you tell us something about the material used for the valve cusps?
Well, it's a proprietary material. It is a form of PTFE, but it's, again, manufactured by industry, and again, it's a proprietary material.
Okay, and then Carlos Miri states, what was the mechanism of the PI seen at 6 months?
Well, one of the interesting things about this valve is that it's actually part of the design is to have small washing jets, which help prevent thrombus formation. So each of the commissures is purposely not completely made to close, so that there is a little turbulent washing effect. And that is the mechanism that is the mild pulmonary valve insufficiency. So it's actually something that's built into the valve design itself.
Well, thanks, Carl. That answered the question of several people on the panel, including also Dr. DeCampley. I'll ask one final question, and then we'll move on to the next section. And this comes from Jim Jaggers. Do you think that the rigid ring has been helpful or protective for valve function?
I think the rigid ring is helpful. I think it helps maintain the uniformity of the valve, and any distortion in the valve cusps can lead to pulmonary valve insufficiency, which then can become a self-perpetuating problem. So I think that the rigid ring is actually quite important.
All right, I'll throw out one more because we still have a little time. Tom Carl states the Yamagishi valve has the best long-term outcome of any known conduit. Will it be available in the U.S.? Do you have any information about that?
I don't have information about that, but I think the idea of this valve is to replicate what Dr. Yamagishi has done and provide the same type of long-term durability.
Well, thank you, Carl, for sharing that information and answering a rapid fire of questions like only a past CHS president could do. This was a wonderful.
That's because I have the new CHSS tie on. So everyone go to the website when it's available and donate to the Kirkland Ashburn Fellowship.
Yeah, the tie gives you superpowers to answer questions rapidly. So thank you very much. We're finishing right on time. This session ends at 11:17, and it is now 11:17. I'd like to thank my co-moderator and good friend Bogdan Marashevsky, and also thank all of the presenters and discussants for allowing us to finish on time. And we will end this session and move on to the next session. Thank you, everybody.